Welcome, everyone. In this explainer, we're really going to sharpen that diagnostic eye for some of the most common skin lesions you'll ever see.
So you look at these lesions. Can you confidently make the call? I mean, this is the fundamental challenge we face every single day in the clinic. A quick glance just isn't going to cut it. Okay, let's dive right in.
Here's our game plan. We'll start with the common benign stuff, then move into the pre-malignant world with actinic keratosis, get into the cool science of DNA repair, and then cover the big red flags from malignancy, finishing up with a super high-yield dermatoscopy guide.
All right, first up, let's establish a baseline. We're talking about the most common lesions you're going to encounter, the ones that are thankfully benign. You've got to know these inside and out so you can spot the outliers that really matter.
And here's our first one, seborrheic keratosis. You will see these all the time. People sometimes call them the barnacles of aging, and that classic description is just perfect. They really do look like they were just pasted right onto the skin.
Now, pay close attention here because this is super high yield, especially for your exams. Under the dermatoscope, you're hunting for those little white dots, the melia-like cysts. But the critical clinical pearl? The sign of lesser trelot. If a patient suddenly has an explosion of these things, it's not just a skin issue. That's a huge red flag for an internal cancer, most often in the GI tract.
And here's what it looks like under the microscope. This is the classic histology. You can see that hyperkeratosis, the thickened outer layer of skin, and the acanthosis, which is that epidermal thickening that gives it that raised, stuck-on look. This is the textbook picture that confirms your diagnosis.
Next up, we have nevi, or what you might also hear called hamartomas. Think of them as benign birthmarks, basically. They're just a localized jumble of normal skin structures. And even though we think of them as something you're born with, they can definitely pop up later in life. Knowing what a normal nevus looks like is crucial for telling it apart from its malignant cousin, melanoma.
Okay, we've covered the benign stuff. Now we're shifting gears and moving into pre-malignant territory. This brings us to our second topic, actinic keratosis, or AK. This is one you absolutely cannot afford to ignore.
So what is an AK? Here's the most important point. It represents sun damage that has already started that journey towards cancer. In fact, it's technically a carcinoma in situ. Every single AK is a warning sign that the cellular machinery is starting to break down.
But to really get a handle on how to treat AK, we need to understand what's happening on a deeper level. So, for our third topic, let's geek out a little on the science of DNA repair. We're zooming way in to the molecular level.
So here's what's going on inside the cell. That UV light from the sun physically damages the DNA. It creates these things called cyclobutane pyrimidine dimers, or CPDs. Basically, it fuses two DNA bases together that shouldn't be. This creates a kink in the DNA helix, messes up replication, and can lead to mutations in critical genes like the p53 tumor suppressor. This is a crucial first step in how skin cancer starts. Now this is where the science gets really cool. There's this amazing enzyme called photolyase. Humans don't make it, but we can put it in a cream. First, it finds that DNA damage and latches on. Then, and this is the cool part, when you expose it to blue light, it uses that light's energy to break the dimer apart, perfectly reversing the sun's damage. It's like a tiny light-powered molecular repair crew.
And the results? They're pretty impressive. Studies have shown that a topical cream with photolyase can remove 40 to 45% of these damaging DNA dimers right after UV exposure. We're not just talking about prevention here. This is active repair of damage that's already been done.
And hey, the proof is in the pictures. Just look at these real-world results. On the left, you've got a grade 1 AK, both what it looks like to the eye and under the dermatoscope. Now look at the right. After 120 days of treatment with a photolyase and SPF 100 cream, wow, the reduction in redness and scale is obvious. This really shows you the power of targeting the root cause of the problem.
Okay, so we've covered benign and pre-malignant. For a fourth topic, we're moving on to the unmistakable signs of malignancy, the lesions that demand your immediate attention. This is where your diagnostic skills are absolutely critical.
So that transition from a pre-malignant AK to an invasive squamous cell carcinoma, or SCC, it's marked by some really clear clinical changes. If you see a lesion that's getting thicker, becoming tender, starting to break down and ulcerate, or bleeds easily, you have to suspect it's progressed, and you need to biopsy it.
And this right here, this is what happens when that progression is left unchecked. This is an invasive SCC.
You can just see how destructive it is. It's extensive, raised, and ulcerated. This really hammers home why it is so important to catch these lesions early.
The other major non-melanoma skin cancer is basal cell carcinoma, which is actually the most common cancer in humans, period. And you have to know its different presentations. You've got the classic nodular type with its pearly border and fine vessels. Then there's the sneaky sclerosing type that looks like a scar. The superficial type can trick you into thinking it's just a simple rash. And then you have the pigmented type, a key mimic for melanoma.
All right, for our fifth topic, let's consolidate everything with a high-yield dermatoscopy guide. This little tool is your secret weapon, letting you see structures that are totally invisible to the naked eye and seriously boosting your diagnostic accuracy. Okay, this table right here, this is your cheat sheet for exams and for the clinic. Seriously, the key is to focus on the vascular patterns. For seborrheic keratosis, you're looking for hairpin vessels. For actinic keratosis, it's that classic strawberry pattern. Squamous cell carcinoma is just chaos, all different shapes and sizes of vessels. And for basal cell, you've got those beautiful, delicate, branching, herborizing vessels. You combine these vascular clues with the other features here, and you're going to be able to tell these four apart with confidence.
To wrap it all up, here's one last challenge. A real exam-style question. A collarette, that's a small rim of scale around a lesion, is a key dermatoscopic finding. Looking at these options, where would you see it? Think it through. The correct answer is E. This feature is a classic sign of both pyogenic granuloma and clear cell acanthoma. You know, it's these little details that take a good diagnosis and make it a great one. So as you go into the clinic, just ask yourself, what subtle clue am I going to spot today that could change everything for my patient?